So to treat the inguinal eye point is necessary a little bit of experience on inguinal hernia surgery. When I was in charge through the surgical unit in Cremona, we were used to do at least 350 inguinal hernia repair every year. So, it's since a long time I'm used to do in this area for surgical procedures. And about the closure with the stitches at the end of the disconnecting procedure of the eye point, regarding the closure of the superficial inguinal ring, I think it's very difficult to perform. And maybe after 3-4 hours, or maybe within 24 hours, the stitches are going to break. So I changed the tactic, and this is an example of a woman. It was a fat woman, really, with with the reflux, valsalva systolic reflux, both from the terminal valve and the eye point. And in these cases, the surgical incision is in the middle. First, you go up to the eye point, then you close, you do everything and you close. Then you do downward to the saphenous-femoral junction. Only one incision, two disconnection. The saphenous-femoral disconnection and the eye point. This is a possible tactic. And this is an image of the eye point. Okay? What you have here? You have the venous plexus, but also the inguinocrural nerve. So you have to search for the inguinocrural nerve. If possible, it's better to spare the inguinocrural nerve to avoid hypoesthesia of the perineal area, especially in young women. You can see here the subcutaneous ring. This is the fascia of the oblique external muscle. And this is the round ligament with both veins and the nerve. In this case, it's very easy. It was very easy to the dissection of the inguinocrural nerve because it was a single trunk. But more often, it's not a single trunk, but the nerve divides in several fibers. So this is the reason why the local anesthesia must be not deep, but superficial, because if you go near to a fiber, the patient will tell you, because the patient feels pain. Okay? Inguinocrural nerve, and this is the plexus. Cutting the plexus, this is an overcoated braided stitch, double stitch here, and then a transfixed shooter. And what can we do with the stamps? The stamps don't have to look one to the other because of neovascularization. So you have to reverse the stamp. Okay. The stamp downward is here, is reversed, and the stamp is looking the arch of the great saphenous vein. And these stitches is the stitches that fix the other stamp, the stamps upward, inside the inguinal canal, so the veins are folded up into the inguinal canal. This is a typical point that normally we use during inguinal hernia surgery, the Barker point. Okay? Because with the transfixed stitch, you go inside and you come out of you pass the fascia at this level, and then you fix with a needle. So, fold it up inside without closing this here, because it's impossible. When the patient moves, the stitches here leave. So it's not necessary. And if they don't need, maybe the woman will have pain. So I don't do that anymore. And why I put 2 stitches and 2 ligation and a transfix point? Because I had one bleeding, only one, and from that I will change my technique. And this is the images that you have at the end of the procedure. Everything is clean, no problem. The skin incision is little, normally 20-25 millimeters. Okay, and this is the P point. I have only one information for you. We normally speak about the classical P point, that is the posterior labial vein, not the perineal vein, the posterior labial vein. All the labial veins goes into the perineal vein, that goes through the perineal transversal muscle, and that join the pudendal vein. But we are speaking about labial veins. The P point is the posterior labial veins, but considering the fact that I had the opportunity to have a good experience in diagnosis and treatment, because I've treated about 900 PLPs. It's a lot. Okay. So what happens? That sometimes you can have an intermediate labial vein, like in this case. You know, this is the classical P point, 8 millimeters anteriorly. You can have another labial vein. Performing diagnosis, you have to search for both, because if the ligation is only in one, and there is also the second PLP, you will have an immediate recurrence. Okay? This is the classical P point, Valsalva, okay? And these are the position of possible PLP in the perineal area. Another very important information, how to prepare the patient for the ligation. PLPs, especially P points, normally it's a small vein. The diameter of this vein range from 1.5 millimeter to 3.5 millimeter, but more often is 2 millimeter, 2 millimeter, 0.3. So it's small. And with the patient in lying position, this vein deflates. So it's difficult to identify. So, in order to identify correctly and to do a correct mapping, and a correct mapping is followed by a correct result of the surgical procedure, is better with the patient lying on the bed, to change the position of the bed. The patient is in lithotomy position, that is the gynecological position. So with the leg fixed on the bed. So you change the position of the bed with an reversed trembling position, so head up and bottom down, in order to inflate the vein. Then you perform the skin mark, and then after the skin mark is finished, you can put the bed completely horizontally. This is the correct way to do. If not, you may have problem, because the skin incision is so little, and it's better a skin incision than a large one, because in a large one you can lose yourself. So it's better a little skin incision, 7-8 millimeters, not more, and you must pay attention about retractor, okay? Because the retractor can move from one side to the other. No, this is not correct. The retractor must work exactly one and the other, exactly, to avoid to move out of the region where you have to do the ligation. Okay? And this is an example of mapping, okay? 2 lines, and where the 2 lines join is where you will find the posterior labial vein. So, This is the correct tactics. You can see here the skin incision, very small. The smaller is, the best is. Okay? And this is the labial vein. You isolate the labial vein with the clamp, gentle traction. You follow the vein and you will find the hole in the vulvar fascia. This is the hole. Polypropylene stitch 6-0. Close the hole with the stump inside. Okay? And in the end, the glue. This is the final result. About the obturator point, what we call obturator point is not the obturator vein, but is the anterior branch of the obturator vein. It's a vein. The obturator vein has two origins, an anterior and posterior branch. The anterior branch normally join the angle between the common femoral vein and the arch. It can join upward or downward respect the terminal valve. Okay? And this is the typical image, echographic image of the vein, the anterior origin, and this is the obturator point, what we call obturator point, and this is the pectineum muscle, the fascia of the pectineum muscle, okay, and the vein can join downward or upward. Different strategies are possible depending on the typology of the varicose vein in the leg. And here you can try the three possibilities you have. Regarding the simple ligation of the obturator point, it's not so easy. I don't like it so much without doing, for example, a high ligation on the great saphenous vein or saphenous femoral disconnection. Because if you go there, you are going to create fibrosis. And if you have to do a second time there with fibrosis, it's not good. So, even if there is fat people, you can use also a microconvex probe to reach the obturator point. Because you use the probe is inside a sterile camera cover. And the steel of the clamp, the steel has an hyperechoic aspect. So you can follow the point of the clamp going down towards the vein you have to ligate. The vein is here. You need calm, no hurry. You must be relaxed. This is the real time you need. Now it will become easier to understand. The vein is this one. We are approaching the vein with calm, slowly, under B-mode control. We are quite arrived to the vein. Okay, then you close the clamp and you push up the clamp. So the vein comes up with the clamp. So you are arrived. Then you remove the probe, you follow the clamp and you find the vein and you can ligate the vein and that's all. And I finished.